Good evening. This evening I'm going to talk about a group of cancers which are very important and are quite different from the ones I've previously been talking about in this series on cancers. And those are the lymphomas, leukemias, and myeloma. These are cancers of the blood cells and bone marrow, and my overall message in this lecture, which is going to be relatively high level because there are a lot of them and this is a very fast moving field, is that the outlook for these cancers has improved substantially for lymphomas, for leukemia, and for myeloma. Some of them are curable and others are treatable. That means they're not completely gone, but treatment means that people can live with them as a chronic condition, rather like, for example, with diabetes. And for many people, they may live with them for years or even decades. Now, the cells you have in your bone marrow and in your blood start off with stem cells, and these can then turn into the white cells, which are largely around protection from infection and indeed protection from cancer, which we'll come back to, or the myeloid cells, which can turn into a different sort of white cell, which is important for fighting infection, but also red cells, which carry oxygen, and platelets, important for clotting. And it is important just to think through what blood does, because that explains why some of the symptoms people have with lymphoma, leukemia, and myeloma occur. The first group of cells are the white cells, and these broadly fight infection and also detect abnormal cells, including early cancer cells. If they're not working, either because they've been driven out by other cells or because they're actually functionally not working well, people can get repeated infections. Then you have the red cells, and these transport oxygen around the body. And if people start to lose those, they can become anemic, and they become very tired and breathless. And then you have platelets, which are very important for clotting. We all get cuts and knocks all the way through our lives. And if you have very low platelets, or the platelets are not working well, people may get bleeding or bruising, which they normally would not get. So the blood is a remarkable series of cells which service in many ways. These cancers, lymphomas, leukemias, and myeloma, occur over the entire age spectrum. Different cancers have different ages where they tend to occur, but they can be from early childhood right through to late old age. And this is different from many of the cancers we've considered in previous lectures in this series. To get some idea of scale, in the UK, there are around 10,000 new cases and just under 5,000 deaths a year from leukemia. There are around 2,000 cases, but only around 300 deaths from Hodgkin lymphoma. Around 14,000 cases and just under 5,000 deaths from non-Hodgkin lymphoma, and just under 6,000 cases of myeloma. So these are important cancers, although not as common as things like breast cancer or prostate cancer, bowel cancer, and lung cancer we've considered in previous talks. They are, however, particularly important as cancers of childhood. Fortunately, children get very few cancers, but of the cancers they get, leukemia and lymphoma are particularly important causes. And in this graph, what you have is the three commonest cancers at different ages along the pathway. In adulthood, cancers we've previously been considering, like breast cancer or prostate cancer, are extremely important. But in children, leukemia, lymphoma, and the third one, brain tumours, predominate. But as I say, they are very rare, fortunately. In contrast to the cancers we've been considering before, what are called the solid cancers or solid tumours, like breast, prostate, lung, and bowel, these cancers should be seen as disseminated diseases right from the beginning. So one of the repeated themes that came up in the previous talks I talked about was the need to catch these solid tumours early before they were disseminated through the body. And if they're localised, you could then cut them out or otherwise deal with them in a very localised way. The cancers we're talking about today are ones which are actually disseminated from the beginning. And therefore, surgery is really relatively unimportant for the treatment of these cancers, but drugs are absolutely essential. And with drug treatment, the outlook, as I say, can be very good, despite the fact these are disseminated cancers. So it is a different approach to thinking about them than you would have in previous talks. Chemotherapy, which is the mainstay, although it's being overtaken in some areas of treatment, dates back really quite some time in history. It was first really used in leukemia, and I'll come back to this later in the talk, back from 1948, using a group of drugs called the antifolates, and they were in turn, because medicine follows twists and turns, possible because of work done by this remarkable scientist, Lucy Wills, who discovered folate when she was looking at why were pregnant women anemic in India. So the pathway there went through to the first chemotherapy drugs, first extensively used by this American physician, Sidney Farber. And the basic principle of the chemotherapy drugs, and I'll talk about a few more of them in the next slide, is relatively simple. They kill cells that are dividing. And since cancer cells are dividing very rapidly and often in an uncontrolled way, they are more sensitive to these drugs and slower to recover. So the good effects that you get from chemotherapy are most effective where you have a rapidly dividing cancer. And many of the cancers we'll be talking about today are very rapidly dividing. They have to be given in combinations. When they're given alone, cancer cells can develop resistance in the same way that bacteria, for example, can develop resistance to antibiotics. They evolve it. So giving different kinds of drugs together in combination reduces the risk of this happening. And they're generally given in cycles. They're given in short pulses over a period of time, allowing time between those cycles for people's normal cells to recover and for them to feel better. Now, the path by which these various drugs have come into treatment has been very varied. And I've just given some of the drugs which are used in these cancers and indeed some other cancers and where they came from. So a drug called vinblastine, for example, was originally derived from the Madagascar periwinkle back in the 1950s. Also in the 1950s, a drug called doxorubicin, which was from a kind of bacteria found around this castle, Castel del Monte, and a different bacteria gave rise to a drug, again, which is quite widely used, called bleomycin. And at the bottom here, a drug called cyclophosphamide, also from the 1950s. This was actually derived from the nitrogen mustards, which are a group of chemicals initially derived, in fact, from things very similar to mustard gas. So the direction from which these drugs have come is very varied. And the drugs work at multiple points along the stages where a cell is dividing. There are drugs like cyclophosphamide that may damage the DNA. There are anti-tumor antibiotics, and these attack enzymes. And then there are things like vinblastine, which stop cells making copies of themselves. So these drugs have multiple effects, and they're used in combination. People, when they're aware that their relatives or that they are going to have chemotherapy, understandably have real concerns about the side effects of these drugs. And they do all have significant side effects. The biggest impact is on cells that are rapidly dividing. And that means they're particularly likely to have effects on the gut, on hair follicles, which are growing, on the mouth, which turns over its cells quite rapidly, and indeed on the bone marrow. And that therefore means they can lead to impacts on the immune system, because of the effect on the bone marrow, bleeding and bruising, some diarrhea or constipation due to the effects on the gut, and hair loss. But most of these last for short periods, some of them a few days, some of them more a matter of weeks, but they are usually short-lived. In a minority of cases, but it is really a minority of cases, people may have, for these diseases, radiotherapy. And radiotherapy also damages dividing cells, and particularly cancer cells. And these cells are in the cancers we're talking about today are often very what's called radiosensitive. That means radiation can kill them relatively effectively. And in these groups of cancers, leukemias and lymphomas, the radiotherapy may be localized, particularly in some lymphomas, but if there's a very heavy concentration in one particular area, or more general. Radiotherapy is actually remarkably well tolerated by many people, with often only local effects and profound tiredness. Tiredness is extremely common, but does recover. And they may have some sore skin around the areas where the radiotherapy is being used. In more general radiotherapy, people can have, rather like with the chemotherapy drugs, some nausea, some diarrhea, but again, these are generally relatively short-lived. People aren't radioactive, and they will make usually a full recovery back, although there may be longer-term side effects in a minority of people, as with chemotherapy drugs. But radiotherapy is only used in a minority of cases, and we're going through these as I go through the different diseases. And the final sort of part of the group of things which in a sense is traditional treatment for these diseases, and we'll come on to the developing ones as we go through the rest of the talk, is stem cell transplants. This is only actually used now in a minority of cases, often in people who've relapsed or in particularly aggressive disease, or in young people who have many years of, hopefully, of life ahead of them. And what this really is that some of the highly effective treatments will kill the cancer, but will also kill healthy bone marrow cells. And therefore, of course, you need your bone marrow to continue to survive and thrive. And what happens is people have the stem cells, which, remember from that slide at the beginning, are what is the precursor for all the blood cells, re-put back into their system, retransplanted into them by usually being infused into their blood. And there are two ways stem cells are produced. They are either harvested from you as part of treatment, so before you have the treatment, stem cells are removed from the blood and then put back again. They're your own ones. You're not likely to react to them. Or in some cases, particularly some of the leukemias, they may be from a matched donor. So someone donates their stem cells, and then they're what are used to reseed your bone marrow. So those are the three things: chemotherapy, radiotherapy, and stem cell treatment. But as I'll come on to, treatment is developing well beyond these now in a number of the diseases we'll be talking about. We'll start off with the lymphomas. These are cancers of the lymphatic system and of lymphocytes, which are white cells, which are very common within them. And the lymphatic system, which runs in parallel to your blood system, drains fluid and waste and helps to fight infection. And you have lymphatics, as on this old woodcut on the right, all the way through your body, and it helps to drain fluid to prevent you from having sort of puffy extremities, as well as I say, getting rid of some of the most important infections and toxins. And you have lymph nodes, and in these, there's the ability to fight infections. And the first way in which people often notice, or their partners or doctors notice, they have lymphoma is where they have glands which are raised in the distribution of the lymph gland distribution. So that's particularly in the armpits, the neck, and in the groin. But the other situations people can pick it up is if it invades the bone marrow, and then they can get the symptoms like problems with infection or fever or bruising, or it may be picked up incidentally. Lymphomas are broadly divided into two groups, Hodgkin and non-Hodgkin lymphoma, but there are many types of lymphoma, and they all have slightly different, or may have slightly different treatment. We'll start off with Hodgkin lymphoma. This was first described by Thomas Hodgkin, quite close, in fact, to where I'm talking today, in 1832. And then subsequently, diagnostic ability to pick it up were improved, particularly the discovery in 1901 by this remarkable woman, Dorothy Reed, of the Reed-Sternberg cell. And this was important, particularly at that point, because swollen lymph nodes were mainly due to TB, but you also had to detect those people who had something else. And what she found out was this rather strange cell, the Reed-Sternberg cell, actually could help differentiate from infection. Still used for diagnosis today. Lymph nodes are swollen, especially of the neck and shoulders, in 80 to 90% of cases, but people may also have what's called B symptoms, and these happen in many of the lymphomas and leukemias we'll be talking about. That's night sweats, really bad night sweats, drenching those sheets, not just a little bit of clamminess, weight loss, fatigue, fever, or itching, which are new. And it's important to stress these are new onset symptoms that persist for a number of weeks. The age distribution of Hodgkin's lymphoma comes in two peaks. There's a peak in young adulthood, late adolescent and early adulthood, and then a second peak in older age. And when there's a possibility that someone could have lymphoma, and most people who've got swollen lymph nodes do not have lymphoma, to be clear, then they may need a biopsy, if it looks a suspicious one, to the doctor who sees them, where it's looked at under the microscope. And they may have scans, something called a PET scan, where a particular kind of chemical is taken up by the cancer and then superimposed on a CT scan, what's called a PET-CT. And this shows where you actually have possible lymphoma activity. And this will show how extensive the lymphoma is and importantly, whether it's spread what's called both sides of the diaphragm, which actually has important implications for what treatment is then given. The treatment of Hodgkin lymphoma is chemotherapy in almost all cases. And in a few cases, it may, particularly where localized, there may also be the use of radiotherapy. Stem cell transplant is only going to be used in a very small minority in relapse cases, but chemotherapy is central. And how much chemotherapy for how long will depend on the stage. In early disease, stages 1 or 2, where it's localized to one area or two areas close to the diaphragm, you have less treatment than in stage 3 or 4, where it is more extensive. But remember, in all cases, it should be viewed as disseminated from the beginning. And if we look at the survival for Hodgkin lymphoma now, 75% of people will survive 10 years or more. In stage 1 and 2A disease, that's when people don't have the B symptoms, it's called limited stage. They will have more limited treatment, generally 2 to 4 cycles of chemotherapy, might have radiotherapy. Around 90% will survive 5 years or more, and most of those will go on to survive a lot longer. In people who've got more advanced disease, more chemotherapy is given, so this might be 6 or 8 cycles of disease, and they might also need steroids and radiotherapy. But even with this more advanced disease, the great majority of people will survive more than 5 years, and indeed beyond that. So 80% in stage 3 and 70% in stage 4. So the majority of people who have this disease will, for practical purposes, be cured of it. And if you look on the right of this graph shows how the survival has improved over time. This is over several decades, and that improvement continues. Most people with Hodgkin's lymphoma can be cured. There is a particularly high cure rate in younger people. It does tend to drop off in people who get it in older age. Most of the diseases I'll be talking about today have much less impact from modifiable factors than many of the diseases I talked about previously. So, for example, lung cancer, very, very heavily dependent on whether people smoke, although not everybody who has lung cancer smokes, but it's a very, very major risk factor. So it's a modifiable risk factor. For most of the diseases I'll be talking about today, modifiable risk factors are relatively unimportant. Hodgkin's lymphoma, there is a very strong association with an infection called Epstein-Barr infection, and also an association with HIV disease. Treatment for HIV disease is important. Epstein-Barr virus, we currently don't have any way of preventing it, and if there were to be a vaccine for Epstein-Barr virus, it is possible that might have an impact on this disease, but currently relatively limited prospects for prevention, but as a good treatment. The other lymphomas, and there are many, are the non-Hodgkin lymphomas, and they can be broadly divided into the fast-growing, what's called high-grade lymphomas, and the slow-growing, low-grade lymphomas. Most of them arise from B cells or their precursors, but you can also have, much more rarely, T-cell lymphomas. I've given here just some of the distribution of some of the types of leukemias and lymphomas, or CLL, which you actually may get. Starting off with high-grade lymphoma, so these are the fast-growing ones. The most common symptoms are swollen lymph glands that don't go down after a couple of weeks. So if it's been there for years, then it's not likely to be lymphoma. And if it comes up, particularly with an infection, painful, goes down again, then it's not likely to be lymphoma. So these are significant swollen lymph glands that don't go down after a couple of weeks. They're usually not painful, and they can occur in the groin, armpit, or neck. May get some B symptoms, these fever and these severe night sweats. High-grade lymphoma is most common in older people. Diagnosis is usually by biopsy, and again, like Hodgkin's lymphoma, PET CT may be used for staging. Now, the aim of treatment for high-grade lymphoma is complete remission, which for practical purposes can be seen as a form of cure. So that is to get no detectable lymphoma, but to do so with drugs with the minimum side effects that you can manage in a particular situation. And this is largely achieved by chemotherapy, most commonly a chemotherapy regimen, quite relatively long-standing one called CHOP, which combines the drugs I've written down here, but also with antibody therapy, which is aiming at a particular marker on these cells called the CD20 cell. And this is, in particular, I'll come on to this, a drug called rituximab. And what you can see on the right is the difference in survival between people who are just given chemotherapy, CHOP, and those who are given CHOP with rituximab, and this leads to a better outcome. And in some cases, people may have stem cell transplants. That's much, again, a minority. So this is the next group of drugs I just thought it was worth pausing on, because these are different from the chemotherapy drugs, targeted antibodies, and they work in two different ways at the moment, and there may well be more in the future. The first is drugs like rituximab, and they target their antibodies, straightforward antibodies. They are monoclonal, therefore they look at a single target against CD20, which is found on the B cells, which are the main cause. And when that's given, they'll lock on to the cancer cells, the lymphoma cells, and that will mean that the immune system, which clears cancer cells under ordinary circumstances, recognizes them and starts to have an effect on trying to clear the cancer cells. So the chemotherapy and your immune system, in a sense, work in concert. A different approach to this is a slightly different drug, and I'm going to give the example of brentuximab. And this targets a slightly different marker, CD30. But what this does is attached to it is a highly potent chemotherapy drug, and therefore it locks onto the cell and kills the cell. But if it was just given generally into the blood, the drug would be too powerful. It would actually cause too much damage, and that would the advantage of the antibodies, it delivers the toxic load very precisely to the cells that you wanted actually to do so. So these are two different approaches to antibody treatment. There are a number of other lymphomas, and I will just highlight one because it has two important aspects. And that's something called Burkitt lymphoma, which actually has several different types. It's predominantly a rapid-growing lymphoma of children. So this is one of the childhood lymphomas. It's rare in the UK, around 200 cases a year, but it's still the commonest non-Hodgkin lymphoma in children. It's what's called sporadic type. However, in Africa, it is much more common, and it's particularly common in areas where EBV, Epstein-Barr virus, the virus we talked about before, and malaria overlap. So it appears to be something to do with the interaction of those two infections. It's called endemic type and can infect the face. You can see children with really quite swollen faces. Also, the third risk is people who are immunosuppressed. And in this childhood lymphoma, people use, again, a combination of chemotherapy drugs and rituximab, and the survival is very good. Survival for limited stage 1 and 2 Burkitt lymphoma is over 90%, and survival for advanced stage is still 80 to 90%. So this is an example of a childhood lymphoma where the outlook is actually very good, provided people are treated. So those are high-grade lymphomas. Now we move on to low-grade lymphomas. These are much more slow-growing, and they're most commonly in people aged over 60. They can present with enlarged nodes or these B symptoms, the drenching night sweats and fevers and more generalized symptoms. Sometimes people can have very mild symptoms or even have no symptoms at all and be diagnosed because a blood test done for other reasons demonstrates that they actually have abnormal blood cells, and then people go on to investigate it. So they may be diagnosed by biopsy, and then, as with other lymphomas, have staging tests. Now, although this is a different approach to the high-grade lymphomas, although full remission, where for practical purposes people are cured, can occur, the main aim of these slow-growing, low-grade lymphomas is control. People can live for many years with a low-grade lymphoma, receiving intermittent treatment, and 55% will live 10 years or more. They may not need treatment at all initially. It may just be a matter of actively monitoring them. But in due course, many will go on to need chemotherapy and targeted CD20 antibody therapy, which may also be used for maintenance therapy. Occasionally radiotherapy, sometimes stem cell treatment. But if you look at the graph on the right, what you can see here is that in younger people, the outlook for people with low-grade lymphoma living with their disease, as you live with many other chronic diseases, can be to live for very many years with really relatively little impact on survival, slightly greater impact in people who are 80 or above. And a number of targeted therapies may be relevant, and I'll just give, again, an example. So these are a different sort of drug group. So targeted therapies are not antibodies, or these chemical ones are not so much antibodies, nor are they chemotherapy. They're not actually killing dividing cells. And the example here is what's called a proteasome inhibitor. And these are things, proteasomes help the cell to break down waste products, particularly proteins that are no longer needed. If you have this drug, it blocks that, the proteins build up in the cell, and it dies. And these are particularly important for some lymphomas, like something called mantle cell lymphoma, and as we'll come on to, myeloma. And there are other targeted therapies if relapse occurs. So you've got the chemotherapy, radiotherapy, stem cell therapy, and then antibody therapy, and then the targeted therapies with chemicals such as these. So those are the lymphomas. Let's move on to the leukemias. Leukemias are cancers of the white blood cells. And rather like with lymphoma, although the nomenclature is slightly different, the rapid ones, the acute leukemias, and the chronic ones, which are the slow-growing in terms of their onset. And they are depending on which pathway from the stem cell, is it down the lymphocytic pathway, which goes down to lymphocytes, or the myeloid one that goes down to granulocytes and red cells and platelets, so those are the two pathways. They're either lymphocytic, so acute lymphocytic or chronic lymphocytic, or myeloid, acute myeloid or chronic myeloid. Those broadly are the four groups. There are many subtypes within them. Let's start off with chronic lymphocytic leukemia, CLL. It's the commonest chronic leukemia. There are just under 4,000 cases a year in the UK, mainly in people over 60. It's very rare under 40, and it's more common, twice as common, in fact, in males. It's caused by a variety of genetic mutations, and the effects of it are both because people have too many B lymphocytes, so they crowd out other things in the bone marrow. They therefore can cause all the problems of tiredness and bruising and so on. And also the lymphocytes that they have are not working very well, so they can get an increased risk of infections. It's usually diagnosed on a blood film. The outlook for people with CLL, chronic lymphocytic leukemia, is that around 85% of people survive for 5 years or more in the UK, and the younger people are, the longer the survival tends to be. The genetic mutations people have are quite a good guide to how long people will survive for. So, for example, one genetic mutation may be associated with a median survival of over 20 years, whereas some at the other end of the scale may be associated with a median survival of 7 years. Although with all of them, the expectation is as time goes by, treatment improves, survival will improve. But as I say, for some of the genetic mutations, in fact, the survival is extremely long. In people with early disease with CLL, no treatment may well be best, and this is proven by trials. Trials have demonstrated that in many early diseases, early forms of the disease, no treatment is just as good as treatment. So why give people the side effects of treatment? Because at this point, no treatment is the best approach. As the disease becomes more advanced, the aim is to control, and it is important, therefore, because it's a long-term issue, to actually have the best side effect profile possible. And the clinical state of the person and the mutations of the cancer guide survival. And usually, this will be some combination of newer targeted therapies, and I've given a list of some of the names, including one we've come across already, for example, rituximab. And with these, the outlook is very good. So many people may have chemotherapy, but not all, and the outlook for the combination for most people is a long number of years living with their disease. Down the other pathway, the myeloid pathway, heading towards monocytes and granulocytes in particular, you have chronic myeloid leukemia, and this is much rarer, around 800 new cases a year in the UK. The outlook over time has massively improved for this disease. There's around a 75% reduction in mortality since the 1970s. This gets more common as you grow older, and again, it has very similar symptoms: infection, tiredness, bruising, bleeding, night sweats, and bone pain. Again, mainly diagnosed by blood film. Now, this one has got a number of important differences to some of the other leukemias we're talking about, but it is essentially one group of diseases around one particular chromosomal change, although there are a variety of ways it can be achieved. First described by Janet Rowley in the 1970s, this is what's called the Philadelphia chromosome. And what happens is a bit of one chromosome breaks off and sticks onto another chromosome. It's not inherited, this is acquired in lifetime. And the resulting mutated protein causes the disease. And what happens is that what we know is this is driven by a particular chemical, a particular protein, and therefore the key drugs are drugs which counteract that effect. And they're what's called the tyrosine kinase inhibitors. And the one which really started us down this path was this drug, anitimab, small molecule. It was a drug by design, so unlike many of the drugs I talked about earlier on, which came via a variety of rather random routes into medicine, given the trade name Gleevec, which is what a lot of people know it by, although there are now other forms of it. and it blocks this protein. And the overall survival before people had this drug and after it was transformational. There are relatively few drugs in medicine which are transformational in that what usually happens is you get small improvements and one improvement builds on another improvement, and over time you get massive improvements, but they're made up of lots of different steps. This drug, initumab, and all the drugs that went alongside it have been transformational, and you can see on the bottom here the difference in survival between those on and not on this drug. But it is an extraordinarily expensive drug, and cost is a major issue. I will come back to this issue of cost in the last lecture series of this whole term, which is on the future of health in the NHS. And in the USA, it reached a situation where this drug, which was given for many years, was over $100,000 a year. But this has transformed the outlook. And people usually started on daily treatment as a pill treatment. And you can see on this graph, which is survival over time in the UK, when the drug was introduced. And this drug was introduced and the mortality just dropped incredibly fast. People can be maintained on this for many years. And if there's a relapse, there are other tyrosine kinase inhibitors which people can use. Much more rarely chemotherapy, stem cell transplant used, really maintained on this as a chronic disease, just as people are maintained on drugs, for example, with diabetes, a chronic disease. It should be seen in that way. So you're not aiming for cure, you're aiming for really good control. Then you move on to the acute form of this, acute myeloid leukemia, down the same cell pathway. Symptoms often vague, tiredness, bruising, fever, bone pain, as before. Main diagnosis by blood test. People may need a bone marrow test. And then for this disease, in contrast to the previous chronic form, which was a single the Philadelphia chromosome, the risk stratification for this is based on factors including gene changes, chromosome changes, cell markers. A whole bunch of different things will lead to the outlook being different depending on the genotype and a number of other factors. So acute myeloid leukemia is a disease of acquired genetic damage. And as you go through life, you tend to get damage to many cells. That just happens. You accumulate genetic damage. Many of them are eliminated by the immune system as you go through. So your immune system is not only scanning for infections, it's scanning for damaged cells. So the ones with very significant damage will be destroyed by the immune system very often. But you will get a large number of largely benign changes as we go through life and age. Most of them have no consequence. But occasionally the damage starts a cell on the pathway through to AML, acute myeloid leukemia. And there are lots of different routes by which different genetic combinations can lead to this disease. And subgroups of cells then evolve as the disease progresses. So the genes the genetic makeup may be turning over. And the outlook for people with AML is determined by the type of genetic damage. I'm not going to go through this in detail, but broadly, in some cases, the outlook will be extremely good with certain forms of genetic changes. And in other genetic changes, the outlook is much less good, and treatment will have a very different impact. AML is generally risk stratified when it's first diagnosed into 3 different categories, and the lowest risk will tend to get straightforward chemotherapy. As you go through the higher risk groups, through the intermediate into the higher risk groups, people may need chemotherapy, but also donor stem cell transplant. They'll need it from someone else. And with age, the outlook gets worse for each of these, but again, you've got the high, medium, and low risk. The worse the genetic damage, the worse the outlook. And as you're older, you have more difficulty, we all have more difficulty in tolerating the more intensive treatments. So it's partly the disease is itself intrinsically more difficult, and partly that we're less able to tolerate the more high intensity treatments. The improvements are steady in AML, so this is different. This is much more typical, so not like this sudden step change, literally a step change with one particular drug class, but there's been a steady improvement, and this is continuing. And in AML, a lot of this is driven by the ability to genotype. So here in the UK, the NHS supports whole genome sequencing for people who've got newly diagnosed disease. And this leads to better decisions about what the right treatment is, whether people should be getting transplant, identifying patients with targetable mutations. And alongside this, there are a steady approach to new targeted therapies, drugs carrying antibodies, for example, to CD33, and also in this group, the tyrosine kinase inhibitors can also be useful. So it's combinations of new drugs informed by the genotype of the person who's got the disease, steady improvement over time. The other acute broad set of leukemias are the acute lymphoblastic leukemias going down the lymphoid side of the thing. Again, around 800 diagnosed in the UK. These tend to be large numbers of immature lymphocytes, and as with the other ones, tiredness, anemia, and bruising and fevers are things which should lead to someone considering it and their doctors considering it. If it's not treated, it can be fatal in weeks to months, so it can really move incredibly aggressively, in contrast to some of the other leukemias and lymphomas. But the outlook for those who are treated is now actually very good. For those under 14, the mortality will be very low, with over 90% surviving more than 5 years and having a long-term good prognosis. Less good outlook in those who are older, but actually this is mainly a disease of children. 2 to 5 years is the most common age to develop it, and it's pretty rare after 24. If you think about chemotherapy for this set, or for this set of diseases, or for ALL in general, the initial treatments were back in the 1940s with the antifolate drugs, which I began this lecture with. And what you can see in this graph on the right is what has happened over the decades. Little by little, survival has improved, starting off with just antifolates, then combination chemotherapy because of the problems of resistance. Then steadily, sequential studies led to improved treatment till we actually get to a situation where the survival now is incredibly good for the great majority of people. And now what we need to aim to do is to achieve the same very good survival, but with fewer side effects. Chemotherapy is the backbone of treatment still, strongly influenced by the genotype that they have. One difference from some of the other diseases we talked about is this disease may get into the area around the brain at a relatively early stage, and people may need some treatment to get rid of those cells because the treatment, general treatment, may not actually kill cells which are around the brain. This is also an area where science is advancing very rapidly, and I'll highlight a very different kind of treatment to ones we talked about, an extraordinarily exciting area of science, but also a very complicated one. And this is what's called CAR-T therapy, chimeric antigen receptor cell therapy. What happens with this is our immune system attacks cancer cells as well as infections all the way through our lives. So all of the people watching this, I will have, cells that could have turned into cancer cells, which the immune system will identify and get rid of. And T cells, in particular, destroy defective cells, whether it's by infection or by damage for other reasons. So CAR-T therapy is when the T cells are removed from the child or adult, reprogrammed to recognize the cancer cell, so inserting receptors for the cancer, and then re-injected back into people. And T cells live for many years, and they then just hunt down cancer cells for the rest of the time they live and destroy them. So if it works, if it's well targeted, they'll live for many years hunting down and killing cancer cells. But obviously if you get it wrong and you end up with a T cell that's targeting the wrong cells, that also could cause problems. So this has to be done very precisely. But this is a completely different approach to treatment, and a highly effective one in this disease, and it may well become important for some other diseases over time. But this is inevitably expensive. It is really a high-intensity science, at least at this point in time. The final group of diseases I wanted to consider was myeloma, sometimes also known as multiple myeloma, just under 6,000 cases a year in the UK. Very rare in people under 40. It's mainly a cancer of older age. And this is a cancer of what's called plasma cells. They're a specialized form of lymphocyte that usually produce antibodies. And there are a variety of different antibodies they can produce, G, A, M, D, and E. And the antibodies attach to and lead to the killing of viruses and bacteria. That's their main function in ordinary circumstances. Myeloma is a massive expansion of a clone of a plasma cell that usually produces the same largely pointless antibody, but there's an enormous expansion of these cells. And the consequences of myeloma is that it displaces other bone marrow cells, so rather like lymphomas and leukemias, it can lead to infections, anemia, and so on. It also, because it can be very extensive in the bone marrow, can lead to the bone being eroded from the inside. So it can lead to collapse of the vertebrae, what's called pathological fractures, compression of the spinal cord, pain in the bone. So management of the bones in this disease is really very important. It can lead to lots of this protein circulating, far more than there should be normally in the blood, and this leads to the blood being very sticky, and this can lead to kidney damage, and it can lead to clots, so people can get deep vein thrombosis, for example. And also, because of the effects, particularly on the bone, it can lead to very high calcium in the blood, which can disrupt the ordinary functioning of normal cells. Myeloma is usually diagnosed by a blood test, and this is looking for either intact antibodies, which are being produced in very large amounts, or fragments of antibodies, what are called light chains, and a variety of ways of doing this. There's an older test that used to be called for Bence-Jones proteins in the urine, but that's really been superseded to a large extent. People may need to have bone marrow biopsies, and they may need to have imaging as well. Now, not everybody who is diagnosed with myeloma needs immediate treatment. This is for many people, a long-term, smouldering, slow progressing disease. And the aim in most people is long-term control and reduction of symptoms and the effects of this disease, not cure. So this is one of the ones which is managed as a chronic disease rather than ones that you're aiming to actually cure it. Its natural history is to be a relapsing, remitting disease with periods of activity and periods of relative inactivity. And what people tend to have is an initial treatment, and then when there are relapses, they'll then have subsequent treatment. The most aggressive treatments which are reserved for younger patients, and these may include stem cell transplants, but they're really for a relatively small minority of people. So initial treatment and then treatments of relapse is the way that this disease or set of diseases is managed. And this is usually combinations of drugs, and they may include a proteasome inhibitor, which we've talked about before, a thalidomide-like drug, and a steroid. And there are a variety of combinations of these, and I've got on this slide here some of the combinations. Now, people, when they think about thalidomide, they think about they think about the fact that this drug, when given in pregnancy, leads to very bad pregnancy outcomes in many children, and that is absolutely correct. So this is not a drug that should be given to anyone who's pregnant or might be pregnant. But of course, most people with myeloma are older, and that's not usually a relevant consideration. Thalidomide is a remarkable drug, actually, used for the right people. It's also used in a number of other settings, like some kind of complications of leprosy. And it stops cancer cells developing. It can stop them developing their own blood vessels, which is very important for them actually being able to grow. And it can stimulate the immune system to attack cancer cells. So it really works in multiple ways. So you've got this combination of proteasome inhibitors, drugs like thalidomide, and steroids. But there are alternative combinations and antibody treatments when people relapse. So there's a periods of treatment and then periods of no treatment when people's disease is relatively quiet. Myeloma survival is steadily improving. So over 80% of people will be alive a year after diagnosis. And from a situation in the 70s where the survival at 5 years was about 10%, it's now over 50%. And just under 30% at 10 years. So many people live for many years, and may well be over a decade. Younger age groups tend to have slightly better survival, but but survival is continuing to improve. So what you can see in the graph is the steady improvement over time, and I think we would all anticipate and hope that that improvement will continue over the next many years. So in summary, today we've talked about a group of cancers where, in contrast to the solid tumours, it's much more viewing them as systemic diseases, some to be cured, some of which are to be controlled. The outlook has improved substantially for many lymphomas, leukemias and myelomas, and I expect it to continue to improve. Some of the things that are moving particularly rapidly are things like genotyping, targeted therapies, so these are not chemotherapy drugs, these are a different approach, targeting these disease cells very specifically, and novel treatments such as CAR T treatment. And these are steadily transforming the outlook. These come at a cost, but they are definitely leading to significant improvements. So when someone next gives a talk about these diseases in a few years in Gresham College, my expectation is the outlook will be better still. Thank you very much.